Professor Leif, we have Dr. T.V. Raja, the eminent foot and ankle surgeon from Chennai. One of the things which many of our Indian doctors would like to know are the experience of episealer in osteochondral lesions of the talus.
Well, our experience is promising and it's very good. We've had the product on the market less than 2 years now, so we have not yet compiled any results data. We have one case report that is now 6 years down the line that works fantastically. He's playing soccer actually with his implant. He's a German fellow, 45 years old or so. So, and the feedback we're getting from patients that are accumulating now is good. So we see no reason to believe why the talus result should not be as good as for the knee, where we have much longer follow-up.
So Dr. Raja, in your practice, how often do you see patients with osteochondral lesions and how do you manage them now?
We do see a lot of OCD patients. The OCD lesions in the talus, more on the medial side, it depends on the size of the lesion. We decide on the management. Very small lesions, we don't do much. Non-weight bearing, and we watch the patients. But if the size starts increasing, about 5 mm, what we were doing now or what we were doing in the previous years was, we used to do scopy, we used to debride the OCD lesions, and then we used to use a BMAC, and then non-weight bearing, gradual loading, rehab. This is what we were doing. Very severe cases where multiple OCDs, recurrence of OCDs, then the option was only fusion of the tibial surface, depending on the age of the patient.
Yes, and that is, in my eyes, fusion is not an optimal way of treating. It's sometimes a necessity. There is no other way of doing it. But if you can avoid a fusion, for example, with an episealer, that would be very good, I think, for the patient.
Yeah, I did hear about episurf or episealer on the talus. And what are the common sizes of episealers or the lesions we can use episealer?
Well, the implant, it's one size implant, 15 millimeter, and that will take care of, I think, a majority of the cases. We are seeing lesions that are slightly bigger. We are in the process of trying to come up with a bigger implant, but so far our experience is such that slightly larger lesions also can be treated with an episealer. You leave a bit of the lesion, but small lesions in the cartilage can heal. We know that, and so if a millimeter or two of the lesion is left, that may well heal. And so far our experience doesn't contradict that.
That's good to hear, and I did go through your episealer brochures. It is individualized cuts and zigs you make for the episealer. It was very interesting and promising to see and hear from you the results, because your research proves that it's a good implant, and it saves the talus, and you can save a patient's ankle from going for a fusion with episealer.
Yes, I believe we can do that, and I also believe that due to the fact that we are actually effectively sealing the hole in the cartilage, I think there are reasons to believe that this may be a long-lasting procedure, because part of the problem with the lesion in the talus is a fissure in the cartilage. Joint fluid is being squeezed down into the bone, and cyst formation, and we avoid that. And so, as in the knee, this seems to be a long-term procedure that may hold up for many years.
Do you have an age limit for this procedure, or it can be done for any patients? And
well, I think there is a limit downwards. You need to have a mature skeleton. I mean, so let's say beyond 20 at least. For patients in their 20s, you may consider biological solutions. We know that. And upwards, I don't really see any upward limitation.
The exact point what I was going to was, is osteoporosis going to play a role in episealer?
Well, that's an interesting question, and I suppose I can only speculate on that. We don't really have a date on it, but I would suggest that that will not be a problem.
Or probably you do episealer with anti-resorptive supplements to the patients?
Could be. Biphosphonates, stuff like that is a possibility. Yeah. Yes.
Professor, you would like to share some of the future